This conference will now be recorded.
Okay, go. Thanks, Nicole. This is Sally Buck. I'm now serving as Chief Executive Officer at the National Rural Health Research Center. Welcome everyone to the TASC 90 webinar today. And we're looking forward to a great call today and lots of good discussion. Just a brief update on the center's transition. If you all received the press release at the end of October, I assume that the new role at the center, and have been working with TASC the past 10 years, but more so in the background of budgets and the reports and applications, and somewhat on technical assistance development. And we'll now be working more on technical assistance and working with the team on some of the site visits and education. Terry will still be working with TASC and continues to serve on the advisory committee, and will also be working on policy, our small group topic meetings, such as this past spring we had the Performance Excellence Summit, and targeted technical assistance and site visits. So you're not losing Terry and just gaining more, I guess.
Yeah, thanks, Sally. And I just want to express my full confidence in Sally, who's been just a key leader in this organization for 20 years now. Sally and I have worked together that long. So I'm excited to be playing a new role here, but with so many exciting things going on, I'm still going to be very much involved, and I would invite any of you that I can help. Make sure you do call me, and I'll be working as hard as I can to support our really excellent team here at TASC.
Thanks, Terry. And today's call will be having our updates from the Federal Office of Rural Health Policy from Dave Dietz and Alicia O'Brien, and then also the Flex Monitoring Team update. And then we'll get into our focus topics for an hour, and that is on EMS, and we'll be hearing from John Gale of the Flex Monitoring Team and a summary of EMS initiatives, and then also a pilot project. And Tracy has some test updates before we get into the ORHP update.
Thanks, Sally. So a couple updates. We have a call coming up on November 25th at 2 o'clock Central Time. For those of you that are interested in participating in a discussion with the Financial and Operational Improvement Virtual Knowledge Group, during that call we'll be discussing what the Flex coordinators are looking for in terms of financial education. What kind of resources or materials are you in need of that either TASC or Flex Monitoring or another source isn't providing to you? Kind of what level of information and what kind of method would you like that information in? Do you already have a resource that either we're providing or somebody else that's maybe in a document form, but you'd really like, a video of it or something? Additionally, we'll talk about things like what are some common questions about finances that you're getting from your CHs that you just don't have the resource or the information to provide on, so that we can do some planning here about some resources to develop for you. And also seeking your feedback about ways to improve some of the tools that are not only coming from TASC, but also from the Flex Monitoring Team, particularly the CH Financial Indicator Report that's released annually. So again, that's on November 25th at 2 Central Time. Other things to note, these Flex State Profiles have been kind of launched out to you to complete annually. There's some new questions in there this year seeking some detailed information, so please take time to complete those. They're due December 14th, and you can complete the web form, oftentimes copying and pasting either from your profile last year and then adding in additional information, or maybe copying and pasting over material from your grant submission as well. But that information really supports all of us in knowing better what each other is up to and being able to model best practices off of each other. And a special thank you to South Dakota, Montana, and Pennsylvania, which were the first 3 states to complete a profile. We're planning for a face-to-face meeting for the National Rural HIT Coalition on February 6th in Washington, D.C., so more information to come on that. We're also planning a spring small group meeting that will focus on rural population health management and how critical access hospitals can meet that coming challenge as the healthcare environment continues to shift, and that becomes more and more of an important concept to remain viable and provide value in healthcare. And then 2 manuals that will be up and coming from TASC include the annual update of the Flex Coordinator Manual, as well as a grant writing manual that will be tailored to addressing grant writing for the Flex program, and that will be released prior to the grant applications this year. So do know that those are in the works as well. And those are the updates I had prepared on behalf of TASC. So I think with that, we'll move into our first set of speakers, then from the Federal Office of Rural Health Policy, David Dietz and Alicia O'Brien, talking about updates from ORHP as well as a critical access hospital regulatory changes update as well.
Great. Hey, thanks, Tracy. This is David Dietz. And Cherry Hill, you're not allowed to retire until there's a consensus vote, so I think you'll be around a while. In any event, just a couple of announcements from around our divisions here, starting with the community-based division. Look tomorrow for the release of a funding opportunity, the Network Planning Program. There will be about 15 grants awarded, each for approximately $85,000 for the year. The purpose of these grants is to assist in the development of an integrated healthcare network. These grants bring together many parts and aspects of rural healthcare delivery systems. Amber Berrien will be the point of contact, so look for that name associated with these grants. And again, these will hopefully go out tomorrow. From the SHIP side of the house, Bridget Ware would like to thank all of those who were associated with the surveys, filling out the surveys. She is modifying the SHIP and preparing the guidance for next year. And on the next call, she will elaborate more on that process, or even prior to the next call. From SOAR, just an FYI here, the NCC for FY14 will be released December 16th and will be due in EHB February 14th, 2014. I did notice that Keith did send out to the SOAR directors the 5-year PIMS trend report. So those of you who are SOAR directors on this call, please take a look at those. The carryover requests are due November 30th. So if you do have a UOB, please contact your project officer immediately to discuss your plans for what you want to do with the carryover. So again, the deadline there is November 30th. From the Flex side, lastly, just to reiterate both Mike and I's communications, the PIMS will be released very early, January 2014. Both Mike and I have looked at it, and personally, quite honestly, it will be an improvement, a vast improvement over the prior iteration of PIMS. It will be much easier, and right now they're just modifying some of the screens. Right now I'm working on the Flex NCC for FY14. Some of you have already contributed some opinions. I do appreciate it, and I will be contacting others of you in the imminent future as I need to get that done prior to New Year's. Just to reiterate Tracy's comments on the Flex state profiles, I strongly urge all of you to take a little time in completing the profiles. You can add anecdotes, you can cut and paste from your narratives and work plans. This is something that the overwhelming majority of you have indicated to me on our one-on-one calls you'd like to see as you plan for the NCC as well as the competitive grant cycle. I think peer learning and peer networking amongst all of you is going to be very important in the coming years. I think every one of you has at least a set of best practices to offer. Some of you have several sets. So please take a little bit of time and fill these out. It's for your benefit. It's for the program's benefit. I think this is very low-hanging fruit as far as effort. And lastly, I just wanted to thank all of you who did volunteer for the Flex Strategic Planning Groups. I'm actually very happy with the response and very excited about it. Representatives from 38 states have volunteered to be a part of this. Later next week, myself and the colleagues will release some information and timelines regarding each work group's set of goals and projects. So please stay tuned. I think this is really an exciting time, and I feel very, very fortunate to be involved in this process. So Alicia, if you want to continue with some announcements.
Dave, just to interrupt you a second before Alicia starts, there's some questions in the chat box about the carryover and the November 30th deadline. Can you just clarify that?
Yeah, I'm looking at it right now. Yes, Catherine Miller. It is just for SOAR, November 30th. Please repeat carryover items. So if you are going to have a carryover request, and this is just for SOAR, please contact your project officer immediately so you can discuss it, as you know, there are contingencies with this and you can only use the funds for certain types of items. So it is important that you talk to your project officer immediately if you will indeed have a carryover request. And this is just for SOAR.
Thank you, Dave.
Sure.
Alicia, if you're ready, it's *2 to unmute your line.
Okay. Hi, everyone. I'm just going to try to go over some of our more recent regulatory updates. I'll try to keep it short. I actually just jumped off of a CMS call on the 96-hour rule. I know it's a really hot, popular topic right now, and it sounds like it's still evolving over there. They're going to have some further guidance coming out, so just keep that in mind. First, I'll talk about the 2 midnight rule, though. Sorry. On August 2nd, 2013, CMS issued their final rule for inpatient prospective payment system and long-term care hospital prospective payment system rates. Under this final rule, surgical procedures, diagnostic tests, and other treatments are generally appropriate for inpatient hospital admission and payment under Medicare Part A when the physician expects the beneficiary to require a stay that crosses at least 2 midnights and also admits the beneficiary to the hospital based upon that expectation. So that's the criteria for the 2 midnights. For documentation, except in cases involving services on the inpatient-only list and in certain other rare and unusual cases, documentation in the medical record must support a reasonable expectation of the need for the beneficiary to require medically necessary stay lasting at least 2 midnights. If the inpatient admission lasts fewer than 2 midnights due to an unforeseen circumstance, that must also be clearly documented in the medical record. And the call that I just got off of, this was a huge piece, just clearly documenting in the medical record. Someone had asked about proper forms and things like that, and the answer just was clearly documented in the medical record. So I just want to reiterate the importance of the documentation. Continuing on, the CMS website is now indicating that they will not, well, and they reiterated this in the call too, I'm sorry. CMS will not conduct post-payment patient status reviews for claims with dates of admission October 1st, 2013 through March 31st, 2014. This was an extension, and they were going to go through the end of the year, and they've extended it to March 31st of 2014. And a caveat to the 2 midnights policy, because the cause receives cost-based reimbursement for inpatient and outpatient services, they won't be under the same level of scrutiny as PPS hospitals. The primary driver behind the 2 midnights policy is PPS payment differential between inpatient and outpatient services. So because that payment would be the same in cause, it's not as critical to cause. And I put the website up there if anyone wants more information to go to that. And that website continues to be updated with the most recent information. So that's your best spot for information right now. The 96-hour rule. Just going to point out here that this has been a condition of payment since 1997, and according to the American Hospital Association, since 1997, as part of a CAW condition of payment, physicians must certify that there is a reasonable expectation that a Medicare patient admitted to an acute inpatient bed will be discharged or transferred within 96 hours of admission to the CAW, if this is the best care strategy for the patient. And this is not the same as the CAW condition of participation for average annual length of stay of 96 hours, but they do obviously go together. According to the CMS State Operations Manual, the standard length of stay, the CAW provides acute inpatient care for a period that does not exceed, on an annual average basis, 96 hours per patient. And they just added on this call that I was just on, CAWs will be paid if, there's two scenarios when they're eligible for payment. And the first is if it's reasonably expected that a patient will be discharged or transferred to a hospital within 96 hours of admission to the CAW, then they will be eligible for payment. And the second one is meeting that above criteria, reasonably expected to be discharged or transferred to a hospital within 96 hours of admission to a CAW, but something unforeseen happens. As long as it was documented by the physician in the progress note somewhere in the medical record that there was a reasonable expectation to be transferred within 96 hours or discharged, then they will be eligible for payment. As long as it doesn't cause the CAW to go over that average, the 96-hour average. So just wanted to throw that out there.
And this is Catherine Miller. I was on that same call, and I just wanted to add for everyone who's on this call, if you didn't have a chance to listen to it, I believe it was recorded, and it was actually one of the best rural health forums I've listened to. And a lot of times they can be really frustrating and not provide a lot of solid information. And this one was really good, and they took a lot of really good Q&A on the 96-hour rule. And what I also wanted to add too, I wanted to see if you got the same thing that I did, that if there is no documentation by the physician and they don't document that they see the patient being discharged or transferred within the 96 hours, and there's no documentation, that they will not be reimbursed. Is that what you got out of it as well?
Yes, I would agree with you. I think they stressed over and over again how important the documentation is. So that's what I was taking from it, is definitely put it somewhere in the progress notes or somewhere in there. Let's see, did I go over the payment? I think I did. Certification begins with the order for inpatient admission and must be completed, signed, and documented in the medical record prior to discharge. Certification is required no later than 1 day before the date on which the claim for payment for the inpatient cost services is submitted. And I know a lot of people have questions, so I think, yeah, Sarah, thank you. Sarah just added the website for the open door form call today from CMS. So if you guys click on that link, you can go there. And as Catherine said, it was a great call, and it sounds like they're going to be taking some of today's questions into consideration and issuing further. I don't know if they're going to do an FAQ or something like that, but it was very helpful. They were still talking when I came over to this one, so hopefully I didn't miss anything that I should be telling you all. I'm going to move on to the Medicare rates for 2014. These go into effect on January 1st of 2014. And as you can see, the Part B deductible will be $147. The standard monthly Part B premium rate is $104.90, which is the same as 2013. There is the caveat for the beneficiaries with the modified adjusted gross income for an individual that is $85,000 or more on your income tax return and $170,000 for beneficiaries filing a joint tax return. They will be responsible for a larger portion of the estimated total cost of Part B benefit coverage. The 2014 inpatient hospital deductible will be $1,216, and the daily co-insurance amount for 2014 will be $304 for the 61st through 90th day of hospitalization, and $608 for the lifetime reserve days, and it will be $152 for the 21st through 100th day of extended care services in a skilled nursing facility in the benefit period. The 2014 monthly premium for uninsured aged 65 and over and certain disabled individuals who have exhausted other entitlements is $426, and the monthly premium for individuals eligible under Section 1818D 4B of the Act, and therefore subject to the 45% reduction in the monthly premium, is $234. I have a slide here on the Aca Outreach and Enrollment, and before I just read it to everyone, I wanted to direct you to our HRSA ORHP ACA website if you aren't aware of it. It's www.hrsa.gov/rural-health/Affordable Care Act. And on that website, we have all of our weekly ACA calls. They're recorded, so you can listen to previous ones, and then you can see the schedule for the upcoming calls. Each week kind of has a different topic, so that will tell you what topics are coming up and who's speaking on them. And you can also, on that website, see the our listserv address, the ORHP ACA listserv, and you can also make suggestions for future call topics if you would like to see those. And I apologize, these were given to me, so I'm just reading them. HHS has released a fact sheet on how residents of rural communities can benefit from the coverage expansion provided by the Affordable Care Act. And then we also, like I said just now, are having the weekly office hours to update rural health stakeholders about the impact of ACA and their communities. And I guess we also wanted to let you guys know that we made about $1.3 million available to support rural health services outreach, grantees to conduct outreach, education, and enrollment activities around the ACA. That's in addition to USDA having made $1.25 million interagency agreements to coordinate outreach activities in 12 states. And we have at least 9 ORHP grantees serving as navigators in the health insurance marketplace out there in rural areas. I think that is all I had today, and I can take questions, or you guys can email me.
Yeah, this is Catherine again. I'm wondering, because you listened to the previous call, when they talked about the OIG report, did you get any kind of feel or synopsis from that? I thought what they said was really confusing. When a hospital, Black River Falls, had asked essentially if they're safe, if they're a necessary provider, if anything happens with the OIG report and they're proposing to get rid of designation for so many hospitals, basically your question was, well, we're a necessary provider, are we going to be okay? And kind of their answer was, well, yeah, because if you're a necessary provider, you're grandfathered in to meet the distance requirements. And that's not what I thought the OIG report was saying. I thought they were saying they're wanting to get rid of even necessary providers. Did you have any input on that?
I think
I'm going to listen to it again because I was confused.
Yeah, I wasn't too clear on that answer either. And I wasn't very clear on the 3 recommendations, where they're going to go from here on that. So
right.
This is Larry Broner. I think what they said there is that if you're grandfathered, you're okay if you're still designated as rural. So if you lose your rural designation, you have to, you know, they could go through, look at you again, and then decertify you as a critical access hospital.
Okay. If that's what they were saying, then I understand. I just didn't catch that.
That's my interpretation of it.
Thanks, Larry.
Okay.
I can try to get some further clarification on the implications of the OIG report. It sounded, again, like there's still some things that need to be determined. Like the first recommendation would require statutory change. So obviously there's some things that are going to be out there, but I can try to get some more updates for next time.
Thank you.
Thanks so much, Alicia. You know, this conversation here makes me think of, you know, there's a need, obviously, for us to send out, you know, clarification messages where we can, or just keep entertaining questions about these really important things that are happening. And I was thinking that some of these things were kind of assuming a lot or kind of guessing on what's going to happen, and maybe using the Flex Program Forum to have this conversation about these couple of different things would be a great location where no one's really sending out an official email on behalf of their organization or anything like that, but we could talk about, well, this is how I'm interpreting it right now, and I'll let you know if I get any more information. So I'd like to encourage us to go into the forum and post some comments or discussion there about these really important things or what we're hearing from our CHs, et cetera, on these topics. And maybe we can keep the conversation going in there in a way that we can all see it, but it's not necessarily public discussion, if that sounds good. If you have questions about accessing the forum, you can contact any of the TASC staff, and we'd be happy to help you out. So thanks so much, and we'll send out, I know Sarah Young put in their chat box information about the call recording that was at Rural Health Open Door Forum, and we'll send out a message later today or tomorrow morning about how to access that call recording as well. So thank you so much, Alicia. I appreciate it. So our next update is on behalf of the Flex Monitoring Team, and John Gale is joining us from the University of Southern Maine and the Maine Rural Health Research Center to provide us a quick update about the Flex Monitoring Team, and then we'll move into our topical discussion for the day. So John, if you're on it, star 2 to unmute your line.
I am on, Nicole. Thank you very much. Can you, I think you can hear me. I'll do two things. The first off is really talk about where we are with the Flex Monitoring Team, and we're pleased to recently received and finalized our notice of the new award for another competitive cycle for the Flex Monitoring Team. So we look forward to continuing to work with all of you. And I'll go over some of the projects that we will be undertaking in the coming year and talk about a few of ours that we have underway that we're trying to bring to a close. The team remains, as always, the University of Minnesota, University of Southern Maine, and University of North Carolina, and we each continue to work with our respective areas of concentrations. So Minnesota is continuing with quality performance, UNC with finance, and we remain focused on the community level activities, community benefit and engagement of hospitals, needs assessment, and state flex performance. And it works out pretty well because we do share resources and input back and forth as we work on projects. But we will continue. One of the big things that we do for the Flex Monitoring Team is to assemble and process secondary data related to quality, performance, financial performance, and community impact and benefit. And so we will continue that for the coming year. We're all continuing to refine and update those measures as best we can. On an annual basis, UNC and Minnesota do quality, the state and national quality and financial reports. On an every other year basis, we do community benefit and impact. UNC and Minnesota, does work on the HIT implementation. So those reports are things for the new Flex coordinators. It's something that we do periodically. We do a state-level roll-up, and then we do a national roll-up, and those reports are available to all state Flex programs. And then we have, in addition to that sort of ongoing monitoring and performance where we pay attention and monitor what's going on based on the data, we are working on and have submitted a draft report and are working through some of the issues about trying to finalize that. A consolidated Flex monitoring team report that would include quality, financial, and community performance measures. One of the things that we've always, it's not entirely new, but we are making a point to really try to work on presentation and making it more useful for the states. Now, for ourselves and North Carolina, this is a little bit easier task because UNC uses the hospital cost report database, and we're using secondary data, so we're not. We don't really have issues related to sample size. Minnesota has a bigger problem just because of the issues related to processing both MBQuip and the hospital compare data in small numbers. But we'll move forward with that and work out those issues so you can see more from us. We're working that through the year. And then for our new projects, we each take on individual sets of projects through the year. We have two new projects this year, since we do an every other year cycle on the state and national reporting. We are looking at the evidence basis for EMS performance measures. And this is, we'll have two components. One is we'll feed into the coming discussions and provide background material for the coming discussions related to the competitive reauthorization cycle for the state flex programs. But we're going to look at the measures and the extent to which different states and different organizations have worked on developing performance measures for EMS. Some of the states that we'll look at include California, Texas, North Carolina, NHTSA, the National Highway Traffic Safety Administration has its own set of measures, and others. So that'll be important, and we will be recruiting some stakeholders from EMS and from the state flex programs. So we may tap some of you to participate in that as we try to work through the selection of measures. Minnesota's going to do work this year on the evidence basis for programs and strategies related to healthcare-acquired infections in critical access hospitals, and that'll be led by Ira Moscovice and Michelle Casey. North Carolina's new project is looking at and exploring the addition of market-level data to the critical access hospital reports, financial reports that they do. And they'll propose to do that looking at trying to identify, using the CMS hospital service area file, try to define Medicaid, using Medicaid discharges, the market area for each CAH, and then link that to some of the socio-demographic data available. And that'll be just more additional resources available on population health. One of the issues I think is a challenge for critical access hospitals is moving forward in this world of population health. What does that mean? So we are looking at the evidence base for population health strategies in small hospitals, and we'll be preparing both some discussion of measures and ways of tracking that for the office, and as they think about the competitive reauthorization, plus products related to an analysis of tools and identification of tools that hospitals can take on. So that, in a nutshell, is a broad sense of what we're doing. I don't know if there are any questions.
Any questions for John about the flex monitoring team activities for the year? Okay. Well, then let's move into our topic for the day. And today's call is really focusing about emergency medical services. The flex monitoring team recently provided a report to ORHP about state flex program ENS initiative that we thought had some really great information on it when it was shared with TASC, and thought it'd be great to showcase some of that information with the flex programs at large, and then also thinking about EMS as well and what's happening with MV-QIP in phase 3. There is that measure about the ED transfer communication, and there's a pilot going on that we thought would be a great opportunity then to provide an update on that. So the rest of the call today is going to focus on EMS, with first John talking a little bit about the state flex program EMS initiatives through the lens of flex monitoring team and on behalf of ORHP from what has been recently reviewed and what some of the recommendations might be going forward in the EMS area of flex.
Great. So I will jump in, and thank you. This is a project that we undertook here at the University of Southern Maine, and we really wanted to get a handle on and think about what states were doing in relation to EMS. It's probably no surprise that EMS is one of the more problematic areas of the FLEX program, partially because it's just such a broad, open topic, and there's so many different EMS agencies and issues that are out there. But it has always been an important part of the FLEX program, and actually in the initial enabling legislation. So what we did is we went back for a 2-year cycle, and I believe we looked at the 2009, 2010, 2010, 11 grant applications, and really began to take them apart and look at and analyze what the states were proposing to do, and begin to think about that in terms of the core area of health services development and community engagement. And so that's the area where EMS falls. And so we, as I go through it, and let me see if I can move this along. Is the right button. There we go. Look at a couple of basic things today. Spend a little bit of time and just give you our thoughts about where EMS is headed. So here's what we'll do today is talk about the requirements and some of the broad categories logic models as part of the report that we put together for the office, and I think they're helpful. I won't get into too much detail on them today, but I think they might be useful for folks who want to look at them and think about them in terms of their activities, and then summarized by some of the observations and suggestions that we have for better focusing some of the state EMS activity. So as we did this, and as you all probably know, EMS is a core area. There are a number of things that states can do. Primarily the focus is supporting EMS and engaging EMS in local or regional systems of care. So as we went through the state grant activity, it's not surprising there is just a wide range of things the states are doing. But we tried to summarize them and capture them in sort of discrete categories, and we've come down to three. One is around integrating EMS into local and regional systems of care, and these can range from involving states in local community health needs, EMS and local community health needs assessments, to more regional and statewide systems of care involving trauma, STEMI, and stroke. EMS training and education is another significant category. And there are two broad areas that the states focus on. One is around boot camps involving EMS leadership and management, focused on the medical directors or the EMS personnel. And the other is training related to emergency department staff and EMS staff, so the CALS and RTDD programs. And finally, and this is the least developed area of flex activity in terms of the number of activities, the performance improvement and sustainability initiatives. So I'll just kind of go through them broadly as we look at systems of care integration. So it varies. You have community health needs assessments. You have EMS involvement in STEMI, stroke, and trauma systems of care. There's a significant activity of CAH trauma designation. To a lesser extent, community paramedicine programs. At least at the time we did this, there were 5 or 6 programs. States involving community paramedicine, we know that's increasing. And then finally, sort of a hodgepodge, for lack of a better term, of other activities, including the development of EMS networks, the representation of rural interests on EMS committees, efforts to examine new community care approaches, and organizing statewide regional stakeholder meetings. And so I think what I'll do is jump into the logic model a little bit for this section, because one of the things that I think it should be remembered is that as Flex moves forward, there's an increasing emphasis on really documenting the outcomes of state initiatives, moving away somewhat from process measures and process-related activities to really trying to come up with things that are focused and have a direct impact on the communities. So this is a little difficult to see. You have the handouts, but basically we went through and began to look at the different strategies that are going on, and I think this might be helpful, because I think where we are in many of these areas are in the short-term outcomes and output stage and beginning to move a little bit towards the intermediate level. So I think in this category, the challenge is to think about how to elevate focus and activities and support for programs that really are going to make much more of a difference, and more specifically engage EMS in the activities. So as we think about this, it's really important as you look at, for lack of a better term, legacy activities related to EMS moving forward is how useful are they? I mean, some of these things may be well liked. They may be popular, but it's important to begin thinking about just what change is being rendered at the local and system level. And so I think if you look at these logic models and think about that, this will give you some guidance. So what we really want to see is the extent to which EMS is integrally integrated into the systems of care. How are they linking with state programs and the local critical access hospitals? As mentioned earlier, one of the things moving through into MBQIP is the transfer measures in which EMS will play a part. So I would argue that it's important to move them move towards a more outcome-oriented and substantive level of activity. As we look at training, as I mentioned, the comprehensive advanced life support and rural trauma team development programs are two very significant levels of flex-supported training. Now, one of the observations I'll make is that as we read the descriptions, and this is only based on the descriptions that we have in some of the follow-up reports and progress reports, some of this training is not as heavily, does not heavily involve EMS as much as might be thought. And so I think the CALS training and the RTTD training tends to focus more on the emergency departments. And so I think it's important to begin to explore ways, when possible, to bring EMS into that mix and create a better sort of collaborative teamwork. The other broad area is leadership training. So there's a focus on medical director training and how to bring medical directors along so they can do a better job. Management related to finance, personnel, and other issues, and sort of general leadership. The other category includes facilitation and sponsorship of educational conferences, webinars, on-site training, some travel funding for personnel to attend different meetings. The states have purchased and disseminated some training resources, videotapes and other DVDs and other videotapes like showing my age. And then support a development of some online tools, which I think are very helpful. But again, there's a limited pot of money to be used, and how can you best use that to engage EMS? And again, another logic model focus solely on education, and I think where we want to see states thinking about this is really those short-term and actually more intermediate-term outcomes. So you're doing this training. You're meeting RTTD on a regular basis, what are the outcomes? Can you get to some measures? Can you get to some sense of whether that ongoing training is making a difference not only in the knowledge base of both EMS and the ED departments, but is it having an impact on the way they function and the way they improve patient care? And that's the important part to think about. And finally, the EMS performance improvement and sustainability. This is a little bit tougher because it means getting involved outside of the hospital world and moving towards a more focused set of activities designed to target and support local EMS units. And that has involved some billing and coding programs and training, group purchasing programs so that EMS agencies can buy in bulk with other providers, movement towards quality and performance improvement, which I think is not surprising given all that's going on in the world of health reform and recruitment and retention. Now, some of the other things that states have done, I know a couple of states have been involved in developing data tracking systems and how they work with EMS units to collect and track data that's useful. There's some technical assistance, and there's certainly a fair amount of support and for participation in and information sharing related to quality improvement networks. And again, back to the logic model for this area, we really would like to, I really think, given that we're in Flex is a fairly mature program in terms of the years of experiences, that we really need to be thinking about moving towards those intermediate and long-term outcomes. So we're engaging partners in quality improvement. We've done some leadership development around training and budgeting and financial performance. What sort of outcomes? Can we think about what those measures are? Because if we're not seeing a substantive change in EMS sustainability or EMS quality performance, then it's worth thinking about whether or not we change the way those trainings are being delivered, or we move to a different way of going about affecting that change. So again, I think this is just useful for thinking about how and where your activities need to be focused. And so as I look at in broad categories, we just thought we'd feeling a little like David Letterman will do the 5 most common EMS activities in terms of numbers, and that was training with the highest percentage being CALS and RTTD. Quality improvement was next in terms of specific activities, not all of them being necessarily as substantive as others, but at least in terms of the reporting. Trauma systems of care, and this is broadly done looking at trauma, system development, CAH trauma designation, and trauma assessment, BIS. The other category of performance improvement, sustainability, a lot of these things are important and well-liked, but they're not that as substantive. They involve supporting meeting travel, training summits, information dissemination. All important, but not, it's harder to roll them up into a substantive impact. And finally, the other systems of care, which again, we get into these seminars workshops, and efforts to sort of move collaborative initiatives along. I think we're probably in the realm of EMS where we were maybe 5, 6, 7 years ago with critical access hospitals. The focus is on the process of networking and collaboration rather than the substance. And I'd argue we have to move in that direction of being more substantive. And the least common activities in terms of numbers, and these by a wide margin, are billing and coding initiatives, involvement in community assessments. STEMI initiatives are fairly small. These are very useful. The ones that have been done, I think, have been very substantive. Community paramedicine and recruitment and retention. Certainly community paramedicine and STEMI are two activities that are growing in flex involvement, but this is the smallest group. So last, I'll jump into our observations from the flex monitoring team. And I've had enough conversation with different EMS stakeholders to think that we're pretty much on target. And certainly in terms of reviewing and reading the flex grant activities, it is very difficult as we read the progress reports and review the grant applications to understand the extent and involvement of EMS in some of the activities. It's not very clear. And so I think that's an important thing to think about as you move forward. It is very, very specific about how EMS is engaged and what they're going to do. We have a continued reliance on process measures. And these measures aren't always clearly linked to desired outcomes. So I think it's important to look back at those logic models and think about how the things you're doing may roll up to a coherent whole as it relates to improvements in EMS performance. Many of the activities are hospital rather than EMS focused, and I think that while the activities themselves are not bad, I don't think we make the progress on EMS that we necessarily assume. A perfect example is the trauma designation process. A lot of the activity in this area is on CAH trauma designation, and it isn't clear how EMS is involved in some of that system building. The same is true for CALS and RTTD training. A lot of the activities continue to support process and support-related activities and less substantive outcomes. Yes, these things have been improved over time in your applications. This is not a criticism, but I do think it's important as the program continues to evolve, and I certainly expect that in coming rounds of competitive cycles, there'll be a greater emphasis on a more substantive body of work and on outcomes so that we can document performance program impact. A lot of the descriptions lack specificity. I hate to say it, but as I read them, some of the language related to the grant guidance is reflected, and I don't blame you there. I always think as you write a grant, you feed back the language that folks are looking for in the categories, but it's hard to determine, so what is EMS doing? They're involved in community needs assessment. How are they doing? What impact are they having? Or is it they just want to benefit stakeholders? And in terms of evidence basis and where I think we observe the best use of evidence-based initiatives really involve systems of care for time-sensitive conditions. These include stroke, STEMI, and trauma training. I think the most substantive body of work has been in that area, in part because there are very consistent and nationally recognized models for trauma, stroke, and STEMI. And so that, for us, makes, I think, an important point is that where possible is to look for and find the evidence base to support your activities. That, by and large, makes it easier to begin thinking about outcomes and impact. In a nutshell, that's what I had to say, and that's what our report really provided to the office. One of the things that we will be doing shortly is we did a very detailed set of spreadsheets by state showing how what states are doing in different categories. We're getting ready, and that will become a product on the Flex Monitoring Team website, and certainly all of you will have access to it, which we'll just break down and let you take a look across different categories of activity, what the states were doing in those 2 years. Any questions?
Thanks. Any questions at all for John?
This is Kenny from South Dakota, and I guess I know you talked a couple times about it sort of from the hospital end on a lot of our reporting. Well, I guess to me that's kind of what we're supposed to report, because we're supposed to be talking about how we're connecting CHs with EMS. So we would be talking from their point of view more than probably more from the EMS, the ambulance service point of view.
And that's a good point, and I do think that and we've had this conversation with David and Megan and Tom at RHP, is that some of the current measures set really are more hospital focused as well, and it's hard to reflect that. But and I agree that part of that discussion is because the goal is to try to figure out how to integrate EMS at the local level more with the hospitals, but I guess it's not clear how well that's happening. And so I think it requires, I'm not saying that it isn't happening, and I want to be careful about that, but I think it's important as we all move forward is to think about how we can capture and reflect information that shows that the goals are being accomplished, and the programs are having a direct impact on local delivery systems. So your point, I think, Kenny, is well taken. I just think we have to begin to think about as a group how we begin to reflect some of those changes.
Other questions or comments for John? So I know here at TASC, we had the opportunity to take a look at that spreadsheet that John was mentioning before that kind of lays out state by state which states are doing all the different activities that they categorize kind of in that John summarized today. And that was neat to look at. So that will be an excellent resource once it's released and available on the FMC website. So we'll look forward to seeing that and making sure that people are aware that that's available. And also, I just wanted to say thank you, John, for the logic model. Those are really great examples, and I think it's really nice to be able to see, the inputs and then walking through the process of the different strategies that could be done within each of these different kind of categories of areas and what actually is the intended outcome and impact of those activities. So thanks for developing those. I think they're just a great visual of what it is that one could try to do within each of those EMS-related activities.
You're welcome. My pleasure.
Okay, so I think we'll move along then to our next speaker, and that is Mary Lou Hader, who will be providing an update on the national pilot project to improve emergency department transfer communication. I just wanted to introduce Mary Lou to all of you. Mary Lou is Vice President, Contract Management and Internal Quality at Stratus Health, which is the QIO based here in Minnesota. And as such, she provides management and oversight for Stratus Health's QIO contract with the Centers for Medicare and Medicaid Services, leadership for the center that provides data analyses and expertise for the organization, and management and oversight for the internal quality improvement and performance measurement activities of Stratus Health. Ms. Hader has extensive background in a variety of healthcare areas, including dentistry, behavioral health, and substance abuse, and general medicine. And prior to her current position with Stratus Health, she held academic and management positions with the University of Minnesota, United Healthcare and Medica Health plans. She received her undergraduate degree from the University of Minnesota and an MBA from the University of St. Thomas. And she is interested in end-of-life care issues and has been a hospice volunteer since 1991. With that, I'd like to welcome Mary Lou to the call to talk to us about an update with this really neat pilot project that's going on that'll kind of impact the work that happens with MD here in phase 3.
Thanks very much. We are excited here at Stress Health about this special innovation project, and it's actually part of the QIO program, and CMS has special innovation projects that they award to different QIOs across the country, and so we're really happy to be able to participate in this one. Carla Wang, here at Stress Health, she's our rural program area lead, and she's actually leading this project, but wasn't able to be here today. So I'm kind of standing in for her. She's our expert with this project. The project goal is to build some capacity and infrastructure in the QIO program for supporting critical access hospitals in working with the ED transfer communication measure, doing data collection, so there's reporting and then improvement related to the data that is collected, taking a look at it and using it for action plans. Our project partners, it looks like there's some slides missing. I think this was the original setup that we had sent in, but wanted to talk a little bit. So there's a couple of slides that you don't have right now, but I'll just talk about this. We wanted to talk a little bit about why are we focusing on the ED transfer communication. And one of the things is communication problems are a major contributing factor to adverse events in hospitals, accounting for about 65% of sentinel events tracked by the Joint Commission. And the Joint Commission has adopted a national patient safety goal to improve effectiveness of communication among caregivers. So this particular measure aligns well with that. We also think that because there's limited attention having been paid previously to the development and implementation of quality measures, specifically focused EDs and other facilities. That's another reason for this project. And then these measures are also important for all healthcare facilities, but especially for critical access hospitals and small rural hospitals that transfer a higher proportion of ED patients than larger urban facilities. Okay, now I'm catching up with your slides. Our project partners are 8 other QIOs in the following states: Iowa, Missouri, Nebraska, Maine, Oklahoma, West Virginia, Wisconsin, and Wyoming. And also HRSA and the Office of Rural Health Policy, as well as the state flex programs in the 8 states that the QIOs are working with critical access hospitals in. The University of Minnesota Rural Research Center, and of course Stratus Health were the lead for this project. Although we're not working with critical access hospitals in Minnesota as part of this project. Some of the background for this project, the original emergency department transfer communication measure was actually developed back in 2005 as part of a CMS special study to identify rural relevant measures, and it was Stratus Health and the University of Minnesota that worked on development of these measures and led that effort. The University of Minnesota in 2007 did submit and led to get approval through the National Quality Forum for this measure. And the NQF is a private, not-for-profit membership organization. It has about 375 members that represent pretty much every sector of the healthcare system. And it has a 3-part mission to first set national priorities and goals for performance improvement, endorse national consensus standards for measuring and public reporting on performance, and promoting the attainment of national goals through education outreach programs. So they're kind of the gold standard for healthcare performance measures. They've so far endorsed about 500 measures that are used in the CMS hospital compare measures. They're all NQF endorsed. So this particular measure is also NQF endorsed. This measure has been sporadically used in some of the states around the country, and here in Minnesota, the critical access hospitals have been submitting data on this measure and are measure, as we talked about previously, someone mentioned, is included in the phase 3 of MB-QIP for all critical access hospitals nationally. We really wanted to work on this project, this pilot project, prior to that happening, but the timing didn't work out that way. So this is a little bit later than we wanted it to be, but the project is moving forward. So we're happy about that. And then again, just to reiterate what the project is focused on, and it's working with the QIO program to work with critical access hospitals on using this measure. So you're probably all familiar with these. The MB-QIP implementation, and you can see that it's in phase 3, that the outpatient emergency department transfer communications. So the measure, actually it's a measure set. There's 7 measures as part of the ED transfer communication set, and their administrative communication, patient information, vital signs, medication information, physician or practitioner generated information, nurse generated information, and procedures and tests. And these are all focused on ensuring adequate information is provided to the next site of care to ensure smooth care transitions from critical access EDs. And this is particularly important, we think, for critical access hospitals to help measure quality and value of the critical triage and transfer role that they play in the healthcare system. So the measures, again, we talked about it's an NQF measure set. This was updated actually in the spring of 2013. So it originally was looking at transfers from critical access hospitals to other acute care facilities, and now it includes all healthcare facilities. So nursing homes across the continuum. So it's been revised and updated to include that. And there's an updated data collection guide that's now available, and you should all have a copy of it. It was sent out with the agenda and the other materials for this call, or this webinar. And there is a paper tool and a list of data elements included as appendices with that data collection guide. We have a pretty aggressive timeline for this project. It's a 12-month project, so there's a lot to do within 12 months. It goes very quickly. It started August 1st of 2013, and it ends July 31st of 2014. So in August and September, the QIOs, the 8 QIOs, recruited critical access hospitals. They were to recruit 10 critical access hospitals in each state. And at this point, there's a total of 101 critical access hospitals that have been recruited across the 8 states. Early in October, Stratus Health, we did a training for the QIOs. So it was kind of a train the trainer on the data collection tools and processes. And then in turn, the 8 QIOs in October and November are training the critical access hospitals on how to use the data collection tool. There's going to be 3 data submissions from the critical access hospitals. The first one will be in January of 2014. And then here at Stratus Health, the data will be submitted from the critical access hospitals to the QIO in each of the 8 states, and the QIO will then transfer that data to Stratus Health, and we'll aggregate the data and create reports, comparison reports. So we'll go back to the QIOs and the critical access hospitals. And so the first of those comparison data reports will be in February of 2014. And then in March and April will be the second data submission and reporting back. And then the third is June and July of 2014. From February to June, the QIOs will work with critical access hospitals on action plans. So by looking at the data, and we want them to use the data identify areas that they can work on in terms of improvement. So they will be creating some action plans around that. And then July 2014, final reports will be going to CMS because the project will end at that point. Some of the pilot resources and exploration that we're doing, we've already provided sample recruitment materials and messages, which we'll talk a little bit more in detail about in a little bit. Updated data collection guide and specifications, the Excel data collection tool. We developed, our analytics staff here developed an Excel tool to use for data collection, along with the user guide that was provided to the QIOs so that they could provide that to the critical access hospitals. Most of the critical access hospitals are using that data collection tool. Although we are working with some vendors to align some data elements, there's a couple of states that critical access hospitals are using vendors to collect the data. So we're working with iVantage and the Rural Wisconsin Health Co-op. Those are two of the vendors that we're working with. The other thing that's happening is the North Dakota Flex program and the QIO are exploring and developing a CART version module for data collection. So we've also provided, or will be providing, improvement tools to the QIOs to work with the critical access hospitals. And then we also are talking about some potential EMS connections. We've been talking with some national EMS leaders about, so we're looking at the ED transfer from the critical access hospital to another facility, but there's that period of time where there's transportation taking place. And so we want to look at that that transfer and not miss a gap there. And Tracy had asked us to, share some best practices during this presentation and some lessons learned. It's a little early in the project for us to do that, so we thought we would just share some of our recruitment messages that we used and advised the QIOs that were doing recruitment with critical access hospitals. So these are some of the messages that we developed around recruitment. So critical access hospitals are increasingly in the spotlight of federal policymakers. It's more important now than ever to participate in efforts that help demonstrate the quality and value that critical access hospitals provide to rural residents.